Today marks the official opening of the summit, and we are excited to kick off a day filled with knowledge sharing and collaboration. First, I am delighted to introduce Regina Hartfield, President and CEO of the Sickle Cell Disease Association of America, Inc. Regina brings over 25 years of nonprofit leadership experience, with expertise in strategic planning, project management, and community outreach. Her leadership has been instrumental in driving forward SCDAA's mission to improve care and raise awareness for sickle cell disease across the nation. Next, we have Dr. Carolyn Rowley, founder and executive director of Cayenne Wellness Center and Children's Foundation, and the visionary behind this summit. Dr. Rowley has not only organized this event, but is also a trailblazer in the fields of nutrition, health psychology, and sickle cell advocacy. In addition to her work at Cayenne Wellness, she established the Machao Orphanage Foundation in Kenya. Dr. Rowley is also an award-winning environmentalist, musician, and educator, making a profound impact on both local and global communities. Finally, we welcome Adrienne Shapiro, Executive Director and co-founder of Access Advocacy. Adrienne became a fierce advocate after her daughter's sickle cell diagnosis was missed due to a false negative test. She has since dedicated her efforts to supporting stem cell research and advocating for better care and housing for people with sickle cell. Adrienne was awarded the 2018 Stem Cell and Regenerative Medicine Action Award for her advocacy. We are honored to have these influential leaders with us today, and we look forward to the wisdom and insights they will share. Welcome to the 16th Annual Sickle Cell Disease Educational Summit. Let's officially begin day 2 and dive into today's sessions.
Good morning, everyone. Welcome to the 16th Annual Sickle Cell Disease Educational Summit, Unpacking Sickle Cell, One Warrior at a Time. It's such an honor to be here and to see so many of you here. I know you have gotten up early in anticipation of an amazing day, and you're going to get that. I want to thank Dr. Carolyn Rowley for inviting me here today to say a few words. As mentioned, I'm the president of the Sickle Cell Disease Association of America, also known as SCDAA. And I just want to take a moment to tell you a little bit about it. First, I'm honored to be here among such esteemed speakers and a wonderful audience, both in person and virtual. For over 50 years, SCDAA has served as the national voice for sickle cell disease. We've been on the forefront of improving the quality of life, health, and services for individuals, families, and communities affected by sickle cell disease and related conditions. We represent a membership of 57 community-based organizations, many of whom are in attendance here today. And that also includes Cayenne Wellness Center. This footprint spans 30 states across the country and collectively serves over 500,000 individuals living with or impacted by sickle cell disease. These member organizations and the staff are on the ground, as you know, every day, raising awareness, caring for, and serving the needs of the sickle cell community. You are a trusted resource and the lifeline to this community, and I applaud the work that you do. I like the title of this summit, Unpacking Sickle Cell, One Warrior at a Time. And after registering, like many of you, I took my really cool, kind of heavy Cayenne swag bag back to my room and began unpacking it one by one when, boop, the light hit me. This is exactly what this entire summit is here to do. take that heavy package, pull it apart, and put it back together. I began thinking about this metaphorical luggage and how within it lies both the problems and the solutions for sickle cell disease. It speaks to the complexities of living with and caring for someone living with sickle cell. We all know some of the issues, and they focus on the need for emergency department reform, increased access to quality, affordable mental health services for all ages. And I double clap for CVS for the support for Cayenne's program. Resources, funding, and services for reproductive health care and fertility preservation. Legislation and policies that are actually passed, that are actually funded, and that are actually enacted. An increase in the number of healthcare providers who provide accurate, timely, and up-to-date information to their patients. Increased access to convenient, quality, and most of all, compassionate care. All the things that make this luggage a heavy load. But the title also speaks to the promise of this new era in sickle cell disease. Here at Cayenne Wellness's 16th annual summit, you will hear from warriors, caregivers, healthcare providers, researchers, community-based organization leaders, advocates, industry stakeholders, and so many more. Individuals and groups who are successfully focusing their efforts on lightening the load of those living with this disease. They're unpacking the old and repacking it with the tools, information, solutions, experiences, innovations to better enable all of us to navigate this challenging yet hopeful landscape for the sickle cell community in this historic era. I want you to know that SCDAA is and will continue to amplify the voice of the sickle cell community, to support and amplify the voices of our community-based organizations, whether they are SCDAA members or not, because we are all in this together. We will not stop until health inequities are vanquished, the full range of treatment options are accessible and affordable, and compassionate care is the standard of care. I thank you for listening to me today. Enjoy the summit, enjoy the swag bag.
Good morning again. And so in your program, I am not going to read it. I hope that you all read it, but let me just share with you. I was having a moment, and that's just because it was supposed to be one page. It wound up being 4 pages, okay? And I couldn't stop because I'm tired. I'm so tired of, we're out there advocating all the time. You guys already know, some of them we advocate for you tirelessly. And as I was speaking to my colleagues, it just feels like we're going back, not forward in terms of care, because we're constantly on the phone. We're constantly in the room trying to make sure that you guys have shorter wait times, that they give you more than 0.5 milligrams of anything. Okay, isn't that ridiculous? And you're just waiting and waiting. And so I'm not going to read it. I really want you to, because it just came out of me and I couldn't stop. But it's what I was feeling, because it's time for a change. And we are going to be marching soon. We can't take it anymore. It's on the side of being ridiculous when people are in the hospital for 5 months. Okay? That's on the side of ridiculous, that they're begging to get help. And the people that can don't. So we have to kind of put a question mark. Why? So again, please read. It just came out and it flowed and it flowed. And I just needed to do this for myself, probably because I was just tired and just said, "Ooh, let me just let everybody know how I'm feeling right now." Please read it. So with that, I'm going to hand this over to Adrian Shapiro, Access Advocacy, who's also the co-host. Thank you.
So good morning. It's so wonderful to see everybody. Um, I'm here standing in front of you, those who remember me from way back when Carolyn had to push me out to even get a hello to anybody, let alone in front of everybody. But I have to say that I knew this day was going to come when I was going to be speaking in front of you, and we were going to have these treatments. And many of you know that I'm like a bedside advocate. I'm the mama bear who I've decided to rebrand as a mama dragon, but that's another conversation. Many of you witnessed me. I'd show up and I'd have more and more bracelets on my arm, honoring every one of the warriors that we lost while I was waiting. And I had 6 magical weeks where we went from the FDA approvals to the Blue Cross announcing, yes, they were going to pay, to where then I knew Medi-Cal was going to have to come. And then HHS said, well, we got some money. And then the state of California said, we got some money. In 6 weeks, 6 weeks, it was there. And my arms had been heavy with these bracelets representing these beautiful souls that I'd had the opportunity to hold along with the rest of the community. And I was sitting down, and all of a sudden I thought, oh no, I told God I was going to wear these bracelets. And now we got it. And I threw those bracelets off. You should have seen me. I was rolling them off, and I was like they were hot. And I had a whole night of just bliss and gratitude. And then the next day I got up and I was like, okay, so now we got to really fix this other stuff, because it's even worse now, because we have these treatments. There is no reason for us to be suffering the way we are. And what I love about our community is that everybody swells up and finds a hole and plugs it in and does the work and shares. So I want to thank you for sharing your time here with us. Because I know you're going to go back wherever you go in your sphere of influence, and you are going to help continue this battle. But as always, we lead with grace, and we leave in honor of what it is we have accomplished, because that now gives us the energy, the foresight, and actually at this point, the resources, right, to face this new challenge of getting better care. So enjoy the summit and get out and have some California sunshine.
All right, thank you. So we're going to start the next session. Regina, thank you for coming all the way out here from the East Coast. Thank you.
Thank you for having me.
It is my pleasure to introduce our moderator for this session, a passionate advocate and community leader, Annie J. Ross-Womack. Annie serves as the executive director of the SCDAA Ohio Sickle Cell and Health Association, where she has championed sickle cell advocacy for decades. Her leadership extends beyond her role in healthcare, as she is also a successful entrepreneur and CEO of a nonprofit organization dedicated to serving disadvantaged communities and fostering minority business. Annie's commitment to improving the lives of others is evident in her active participation on multiple boards and her continued efforts to uplift and empower her community. We are thrilled to have her moderating today's discussion, as her experience and insight are invaluable to this conversation. Please join me in welcoming Annie J. Ross-Womack.
Well, hello, California. Hello, Dr. Raleigh. Hello, our leader, Ms. Regina Hartfield, and all of those who are there in person soaking up the California sun. Wish I was there with you, but as you know, September is National Sickle Cell Month, and I have been transcending and running across the great state of Ohio, doing the business and doing the work at home, as was stated there. We have a great session for you today. And I would allow my young woman that is on stage there to introduce herself to you. And then we will get started with what it is that she will bring to the table, as well as what you in the audience will hear today. We will have a power pack session for you today. And we ask you that you take notes, take that information back with you and share it with others. Information is only good when it is shared. So I will cease and I will allow our young individual on stage to introduce us.
So
Good morning, everyone, and welcome to the 16th Annual Sickle Cell Disease Educational Summit. In this session, Wise Guides, Sickle Cell Community Highlights, we have an outstanding panel of experts who are leading the way in sickle cell care, advocacy, and education. First, Dr. Paula Tanabe from Duke University, a pioneer in improving emergency department treatment for vaso-occlusive episodes, with a focus on individualized opioid protocols. Joining her is Dr. Caroline Fryermuth from the University of Cincinnati, who is passionate about educating emergency professionals and advancing evidence-based care for sickle cell patients. Next, we have Yvonne Carroll, the program director in hematology at St. Jude Children's Research Hospital. Yvonne is not only a nurse and lawyer, but also the co-founder of the Sickle Cell Nursing Bootcamp, which has trained hundreds of nurses in the U.S. and internationally. Her dedication to educating healthcare professionals and improving sickle cell care has made a profound impact in both research and advocacy. From the community side, Michael L. Matthews, Executive Director of the Children's Sickle Cell Foundation, has been instrumental in creating impactful programs like PA Living Well with Sickle Cell Registered Trademark and the Synergy Project ECHO. Alongside him is Reverend Zemoria Brandon, whose leadership and initiatives like Shine the Light on Sickle Cell raises awareness every year for World Sickle Cell Day. We also have Ariel Kraimbu from Sick Cells, who advocates for patients on Capitol Hill, promoting health equity for marginalized communities. Finally, Ashley Valentine, co-founder of Sick Cells, brings a deeply personal story of advocacy, having cared for her brother through his battle with sickle cell. This incredible group is here to share their experiences and insights. Let's give them a warm welcome as we dive into today's discussion.
All right, a round of applause. All of the speakers that are here in person, if you don't mind coming on stage, please and thank you before we get started so that it is super easy for us to transition from one person to the other. If you're here. All right, well, they're not. All right. So back into your hands, Miss Annie.
Well, for our first speaker, Dr. Paula Tanabe will give us an update on what she's doing, and then we will go in order in making sure that we hear. And again, take notes. Take notes. Dr. Tanabe, I'll give it over to you.
Okay, good morning, everybody. Are you able to hear me?
Yes, we are.
Okay, great. I just want to thank everybody for this opportunity. I'm really excited to be able to be here and to share some updates and to share a really positive perspective about a lot of things that are happening in the emergency department. You know, at the beginning there, we talked about there's a lot of positive with, the new gene therapies, et cetera. And yet there's still a whole lot of challenges. So I just want to make sure everybody's aware of all the good things that are happening. So I am going to share my screen, I think. And tell me if that works. And I do wish that I was there in person. But again, it's Sickle Cell Awareness Month and I've been pretty busy. How does that look?
It looks
It
great.
is great.
Okay. All right. And I actually just made an update. So again, thank you. And let's get going. So I'm going to report results from several trials about really using evidence to how to support using individualized pain plans to treat vaso-occlusive episodes in the emergency department. Then I'm going to give you a little snapshot view of some really exciting work that's going on in the state of North Carolina. But even more, and I just got off a call, actually, many of you probably know Dr. Fasipe, who she was on the panel for the CMS measure that actually has been submitted. So I just was actually updating a slide that I had about what I was going to say. So I think there are some really, really, really positive things happening. And I hope we walk away with hope. It sounds like the panel will be a little bit later, and I apologize, I won't be able to join that panel. So these are my disclosures with the funding that supported all the grants. So as we all know that there are evidence-based guidelines from 2014 with National Heart, Lung, and Blood that actually advocated for treating within 60 minutes of arrival to an emergency department. And that is with parenteral and that is with opioids. And then the American Society of Hematology in 2020 also endorsed individualized pain plans, again, being treated within 60 minutes. What these guidelines basically say as a summarize is that first we need to recognize the problem as really acute. And with triage systems, a level 2 is really the correct triage level, that we need to treat rapidly within 60 minutes and to thoroughly treat, so to reassess within 30 to 60 minutes and to treat again with pain medications until pain is actually resolved. And then finally, be specific. So whenever possible, using individualized pain protocols, considering what the individual person has taken. Some people need chronic opioids, and so that should be taken into consideration. And when that's not possible, we should be using a standard protocol, not variability based on whatever doctor or whatever nurse is working that day. So that's really where a lot of the work that I focused, because when these guidelines came out, they were all based on expert consensus panel, which is great and wonderful, but always not the highest level of evidence where there was a trial to say, yes, individualized pain protocols are better. And when you go back and when you partner with your emergency colleagues, it's important that you understand the evidence, because the evidence that's been generated since the guidelines is a higher level of evidence. And that is really what you need to be able to go back to work with your colleagues in emergency medicine and in the hospital so that you understand this is a higher level of evidence and that you have that evidence. All of this has been published. So the first one that we published was a randomized control trial comparing the two protocols for vaso-occlusive crisis in the emergency department. And our main outcome was a change in pain scores, actually, from arrival in the ED to discharge from the ED. And we were comparing those pain scores and improvement in pain scores to individuals who were treated with a standard protocol. And for this trial, we define that as weight-based opioids. So whatever your weight is, there are formulas on what dose you should get, or a patient-specific protocol developed with the hematologist about what you need to treat your pain for a VOE. And then equally important in my mind was questions about safety and side effects and the pain experience. Because if we are going to need to give higher doses, we need to know that it's safe, and that evidence needs to be published. I'm going to go through the first trial in more detail, because the second one was pretty much the same with a few key differences that I'll point out. So this is a randomized control trial in 2 busy EDs with adults, and we allowed them to contribute up to 5 emergency department visits. It's a very tricky trial to do. So this grant was really kind of the pilot of, can we do it? Because it's really very, very tricky. So first of all, patients had to be pre-enrolled, usually in the clinic, and sign consent. And then after they were consented, then it was determined if they would have an individualized or a weight-based dose, and then following the NHLBI recommendations, so reassessment, readministration of pain medications. So that protocol was written with patient, and the protocol was then uploaded into the electronic health system, which a lot of times was Epic. And then we waited for individuals to come to the emergency department because you never know when you're going to have a vaso-occlusive episode. So if they showed up, then the protocol was visible to the ED provider once they went to order something. They were educated about the trial. They did not have to follow the protocol. And so we measured to see if it actually was followed as well, which is another piece of information that's equally important. So the other tricky part of this is that we knew that we had to have research staff in the ED. So there were research staff there waiting. And then once a patient was placed in a treatment space, then we started collecting data. And we collected data every 30 minutes from placement until there was a decision to discharge from the ED or admit to the hospital, or at 6 hours. If people were still in the ED at 6 hours, we kind of said that's, enough. So our primary outcome over here is change in pain scores from arrival to discharge, as I just mentioned. And we had to use a 0 to 100 scale where our patients would mark on the scale because it's easier to do statistics with. And then a 13 millimeter difference has actually been found to be clinically important and meaningful to a patient. If you can reduce your pain by at least 13, that's important. So we looked at that as well. And then every 30 minutes, we also got vital signs, sedation scores, and side effects from the patient directly. So we really didn't have to rely on what was documented in the chart. This is really important to get all this valid data. And then we did have other questions on patients' satisfaction with pain management. And another paper is going to be coming out on that pretty soon. We're really confident about. So here are our results. So we ended up with, I think it's 52 different people totally, but 126 different emergency department visits. And so what you see is the reduction in pain score. So for the individual patients on an individualized pain protocol, their pain went down an average of about 52 or 42 millimeters plus minus 7. And on the standard, it was about 27, again, plus minus. So that difference was 15, almost 16 millimeters difference. And so in this trial, it was both statistically and clinically meaningful difference that patients with individualized protocol really did have a bigger reduction in pain. So then we looked at some other things. So again, we have individualized here, and this is the standard. So really no difference in the 13 reduction between. These are some of the other questions about satisfaction. Was their goal met? So still there's an opportunity to improve and to do better. Patients needed more pain medication, and then satisfaction down here. So I think if you combine the very and the somewhat satisfied, about 77% of people were at least somewhat satisfied, and there was no difference between those groups. The only place there was a difference was it looked like if you had an individualized protocol, you were less likely to need to be hospitalized. However, the study wasn't powered, so we didn't have enough patients to confidently say that, but it looked good. And you could see the readmission to the hospital and the ED revisit rates as well. Now, this slide is also super important. And it does show that patients in the weight-based, for some reason, it looks like they had more nausea. And what's really important is we looked at naloxone, which is a reversal drug for opioids. So that if you give too much pain medication and their respiration slow, we need to give naloxone. We had none of that. So in neither protocol had the need to administer naloxone or had respiratory distress or having to intubate someone or help them, with their breathing. So that's really, really important because we're able to show really validly because we had a research staff there at the bedside. And then they did also look in the electronic health record to make sure we didn't miss anything. Yes, there was some supplemental oxygen, no difference between the groups. Their oxygen rate is 95. You can see that. Sedation, there was a little bit of severe sedation, but again, nothing that required anything more than a little oxygen. And so really no differences here between the groups and no really bad side effects. The other thing that we looked at, you'll see the darker line is the individualized protocol and the other line is a standard. And what you see down here is time in minutes, and this is the pain scores. So patients who received the individualized dosing saw a more rapid reduction of pain at 120 minutes, so about 2 hours, and then it stayed there. So if we really got on top of their pain, it went down quicker and it stayed there. So I think that was an important finding. So in conclusion of this one, patients who got a patient-specific protocol versus a weight-based did have a greater reduction in pain. Both protocols were really safe. Hospital admission looked like it was less in patient-specific. And patients in the patient-specific did have a faster reduction in pain starting at 120 minutes. So that sounds great. But at the end of the day, it was only 2 EDs and only 52 different patients. So we needed to do another study. So we applied for more funding, and we were funded by NHLBI to conduct the Compare VOE project, which is very similar. And so we have published this in Academic Emergency Medicine, and you should have these references for sure. So now we have 6 sites, 2 in Michigan, 1 in Ohio, and then Maryland, North Carolina, and Texas. Primary outcomes were the same, and the discharge criteria were the same, and our secondary outcomes were also the same. Again, we did a randomized controlled trial. What was different is this time we only allowed 1 visit per patient because we wanted to get more patients. And so based on the other trial, we knew that about half of the patients who consented and were included actually would have an ED visit in the next year. That was in the other trial. So what we determined is we needed to have 230 people who actually had an emergency department visit. So we were targeting enrollment of about 460 people. So we did the same thing. We pre-enrolled them. They were randomized to individual or weight-based. And we have a difference here in that we wanted to walk away with something that hematologists could use to determine what that dose should be, because hematologists are not pain docs, and that's always a challenge for them, how to write your pain protocol. So we worked with several experts around the country to develop a calculator on Excel that could be used. And this calculator was used, and we worked closely with the hematologists to make sure they were comfortable with it. Protocol was loaded into the electronic health record again, and then the same protocol was followed. Patients were then interviewed from placement in a treatment space to every 30 minutes until either decision to admit, discharge, or 6 hours. So this is a little more on the calculator that we worked together. Dr. Kavanaugh and Dr. Strauss at Duke, and then Dr. Pace was an expert in pain. Lots of work really to validate this. And the good news is that this calculator is now available with instructions on the website for the National Alliance of Sickle Cell Centers. When you go to the resource tab, you'll see it right there. So this is really great that it's up there as a resource. So we're happy that this came out of the trial. So what happened actually? So we needed to enroll 230 people. And we started the project November of 2019. You can all guess what happened then. So we ended up actually consenting 329 patients. We ended up with 104 patients because come, February, March of 2020, patients stopped coming to the emergency department for anything. Research staff all got diverted to COVID protocols. And so we really struggled. We continued to enroll and consent people during that time as a remote thing, put their plans up. But basically what we ended up then was with 96 people, not 230, but 50 in the patient specific and then the weight-based. And what was really interesting at the end of the day, when we did analyze the data, we made that calculator to be very safe. And that showed. And so at the end of the day, people in both protocols got about equal doses for the first dose. In the patient-specific total dose, they got about 35. Everything was converted into morphine equivalents. So they got about 35 plus or minus 30 milligrams of IV morphine versus 39 plus or minus 28, which is essentially the same. First dose was about 10 in each group. So, you know, we have 2 strikes right now. We didn't get enough patients that we needed, and the dose in the 2 protocols was the same. So what did we find? Well, you can guess that we found no difference because they didn't, because of the 2 reasons I just said. So about a 27 millimeter reduction in both protocols. And so that actually is good news because that's a pretty important number. You know, if you look at the median overall was 16 and 25. So both of those, all of these numbers are clinically important reductions in pain, which says that you can actually be treated with either. But again, they got the same dose. So you can make more assumptions, and we could talk about that all day. But the good news basic is that there was a good reduction in pain in both protocols. And this is the 14 or the 30% reduction in pain, no difference there either. What was different is the emergency department length of stay, which is a nice little negotiating fact that you can use with ED providers. So those in the patient specific had a shorter overall length of stay in the emergency department. You know, this is a majority of patients here within this box. These are all kind of like outliers. So you can kind of tell the difference was really about 45 minutes. So if you were treated with a patient specific protocol, you were in ED about 45 minutes less. That's important in overcrowding. Equally important is safety. And what you don't see on this side is Narcan or intubation or any of that. And that is because, again, it did not happen. So it did not happen. Yes, there's, you know, some nausea, vomiting, some itching, moderate to severe sedation, you know, a little bit of that. But again, that all responds to oxygen. And that's important because then we do need to hold back opioids. When you're that sedate, on a valid sedation score, we have to be careful. We have to be safe. We can't over medicate. And so you can see that, again, safe, very safe. Adherence to the protocol, I did not show you this on the prior trial, but it was the same. So this is really important. When we put the protocols in the electronic health record, the physicians in the ER followed it. So, you know, the medication name, 95% of the time they said, yeah, and they did. And we looked for the doses, we looked for the drugs, and we carefully measured this. So they did give the drug, they did give it by the route, and the milligram was off only by like a 0.1 milligram. So they really did follow the protocol, both in this trial and the other trial. And so now that's 8 hospitals. So in conclusion, COVID-19 was a problem. Our study was underpowered. Both, you know, groups got the same. The calculator is great. It's out there. Both protocols are safe. Both protocols had a good reduction in pain score, and the patients with a patient-specific were treated quicker. So I'm going to move now onto Align and talk about Align. Which is actually putting individualized pain plans in the chart for not only the ED director, but for the patient as well. And I think this is really, really, really an important trial, and it's an implementation trial, which means, can we do this? But the goal of this, again, is to improve treatment in the emergency department by following the NHLBI guidelines and by embedding these plans in the EHR for patients as well as providers. Our primary outcome was patient satisfaction with the quality of ED care. Our secondary outcome was provider confidence in the ED. We have 8 sites here. This was part of the Sickle Cell Disease Implementation Consortium, and this trial was led by Dr. King and myself, and you can kind of see where the sites were. So this is an adults only with cell phone. They had to have had a visit to the ED in the last 90 days at that particular site because we didn't want your satisfaction of a bad visit from 20 years ago. We wanted your recent satisfaction. And people had to have a visit at the clinic within the last year. the ED providers, pretty much any ED provider who agreed to participate and would do a baseline survey, and then they would be included again if one of the patients who enrolled had an ED visit. So also really important is that 6 to 8 of these sites did have IPPs in the electronic health record already for the ED, which meant they were already working together. None of the sites had put them in the EHR or the patient portal at baseline, and that was required for everybody. So at the end of the day, what we ended up with, we had a lot of surveys, over 300 and some surveys, because patients could complete a bunch of surveys, but we only used their first one. 153 that did baseline and that had an ED visit and completed the follow-up survey. 135 ED providers, same thing, baseline and did a follow-up because they took care of a patient. The question that you probably know is a 3-question for the patient about their perceived quality of ED care, about the nurses, the overall doctors, the overall care, and how they were able to manage their pain. So we use Likert scales. The ED providers completed a brief survey on how comfortable they were caring for patients. So this is sort of an overview, and I'm not sure how it's projecting, but there were 8 sites. We trained all the ED sites a little bit on sickle cell, on triage, on DEI, and implicit bias. And the hematologist worked with the patient to write the pain plan. This time we didn't tell them how to write it. Pain plan got added to the EHR for the ED provider so that they could see it, and to the patient portal. So our research staff did have to do some work sometimes with patients who were not already signed into their portal. And as an aside, I think this is a big takeaway for any kind of warriors in the room. If you don't have access to your portal, you need to get it and work with your hematologist and your sickle cell doc to get your plan in the EHR in your electronic health portal, because this is where it looks really real. They can see your patient plan, your pain plan in your chart. So you could walk with your plan pull up your plan on your portal in your EHR, and it will look real. That's the challenge of pretty much anything else, because you bring letters asking for opioids. With an opioid epidemic in this country that is very real, the letter will be tossed. And it's not because you're sickle cell, it's because it has opioids in it. So getting that plan in your portal is really critical and something that you can actively do. And then we would get the feedback from the patient. They would get those 3 questions via text message within 3 days, and then they filled them out. And the ED provider got an email after they took care of that patient. They did it at baseline, but then after they took care of a patient, they completed the survey. So what we found, and again, this goes back to 6 of the 8 sites were already working with their EDs. Patients were actually pretty satisfied at baseline, and so then they were satisfied at follow-up as well. And so there was no improvement in satisfaction scores. But the ED, and same with the ED providers, they were pretty comfortable at baseline and they were pretty comfortable at follow-up. Now, we actually asked the ED providers at the follow-up, would they order the recommended drug and dose? And yes, they said, of course we would. And they intended to use the IPPs. So the ED providers just need some help and some guidance. And when you give them the right dose that's written by their hematologist, they will follow it. But we need to make it easy for them. So this is some of the patient reported ease of use, and 7 is extremely easy. So this was the first, so this is everything now. So this is, a post-study visit. You can see that we had pretty high, how easy was it to find? Because again, this is implementation study. Can we do this? And what you can see is it was pretty easy to find for about half. 57%. There are people where it wasn't easy to find. And the sites did it a little bit differently, but several of them put it in a letter that you could go into your portal and click the communications tab, letter, and then pull up that letter. There are different ways to do it, and we're happy to do follow-up questions on that. And then how helpful was the pain plan in getting you the treatment that you needed? And you can say, 55, there's still room and opportunity for improvement, but, pretty good. And this is ease of use. How likely are you to show the doctor your plan? So pretty good. I reminded them. Some of them didn't because they already knew that the ED doctor had seen their plan already in the EHR and were following it. So that's some of it. Conclusion of this, which is important, again, this is implementation. Sites could do this. So hospitals and EDs, hematologists and EDs could work together with IT, the information technology, to get it in the record, not only for the providers in the ED, but for the patients in your portal. And that is a key takeaway, that it can be done. And then when we actually asked the patients and the providers, they did endorse. They were pretty positive about the IPPs. So the next thing I'm going to move to is some of the really exciting work in North Carolina. North Carolina in their legislature has a governor's council on sickle cell disease and do a lot of really good work to improve sickle cell disease. They have a medical research committee that meets, and they were charged with improving the care in the ED. So there was a large group of physicians, nurses, community-based organizations, warrior inputs from across the state that met for over 2 years, that I was fortunate to be able to lead this group. We developed a toolkit for emergency departments to help them. We are disseminating. So on September 3rd, the day after Labor Day, we took the top 5 of the top 20 hospitals with the highest number of ED visits, and we disseminated the toolkit with a letter to the CEO or president of the hospital and the ED medical and nursing directors. And the letter was signed by the government council or governor's council and the state level officials, excuse me. So the approach this time, which is different than what I've done before, is, the teeth of the Governor's Council, Department of Public Health behind this project. And really, it did take 2 years for us to all meet together and develop the kit. The toolbox contains a template for orders, some things at the top, like, oh, beware, this person's have a Lextor. And then there's a do this, the individualized pain plans, labs, and don't do this. This is how it's set up. And this was actually from Dr. Jane Little, who is now at UNC in North Carolina, was previously in Ohio. And then there are some core principles, things like triage this person's a level 2. DORA first pain meds should be 60 minutes. You should have individualized pain plans. Don't have anybody write them, use weight-based. The other thing that we did that is very helpful is we're offering carrots to the EDs, where we offered a sickle cell expert and an ER expert to each hospital to reach out to help them implement them, to talk. And in the letter, what we asked for was the name of someone within 2 weeks that then we could reach back out to and help with. And then we also included a list of quality improvement indicators that these EDs could start looking at. For example, time to first pain med in 60 minutes, ESI triage level. So that's a toolkit went out electronically, and it's also going out hard copy to all 3 of those places. We also included the individualized pain plan with the calculator. Okay, and the good news on that is I was really afraid we'd have just radio silence. No, we have heard back from 4 of the 5, and we heard back from the presidents, and we have the contacts. And now we are actually setting up meetings with 4 of the top 5, and it is really wonderful. So that's kind of the toolkit. So that's out there, and we're starting, and it's pretty exciting, but not quite as exciting as this. So I actually just got off the phone a little while ago with Dr. Fasipe, who was on this panel. And so the American Society of Hematology pushed Centers for Medicare and Medicaid Services. And this is where hospitals really have to comply, because if they don't comply, they can lose their Medicare funding. And there are many measures EDs have to reply on, have to report on, quality measures. things like time to first EKG, time in sepsis patients, et cetera. So they have worked for several years with CMS and ASH to submit a measure. And actually last week or the week before, they had a town hall. In April, there was a document that was put out for public comment. And, many people commented. The group got together again several times. They worked together. And so per Dr. Fasipe, with the latest on this measure is that it is now submitted, that actually CMS was very positive about the measure and they really liked it. So while it isn't adopted yet, it is a promise that it will be adopted and it is moving forward in the process. I'm not sure if there's another public comment period or not, but it's been submitted again and under review. The measure itself be a little more, but it is time to first pain medication for patients with a diagnosis of sickle cell disease. There was some concern that it didn't say opioid. And this was talked about a lot. And so also included sites will have to report the pain medication and the route, because we don't want EDs to game the system by just giving you a pill of Tylenol. So there apparently was a lot of discussion about this, and this is the place to start though, because it needed to get through the American College of Emergency Physicians. We had to have their buy-in in this, and this is the way that it would happen. So the thought is this measure will be applied and out in December sometime. And what I wasn't clear on, and now I am, is that it will be a mandatory report. It will be one of several measures that EDs have to report as part of their outpatient quality hospital emergency report, or if appropriate, their rural emergency hospital quality report. So this score, they'll report the time and then it will be interpreted as good or not. And apparently it will be interpreted as good or not if it meets the 60 minutes. So while they're going to report time, it will then be sort of graded and assigned a score based on if it met the 60 minutes or not. So EDs are going to have to start looking at this. And this is super exciting because this is where now everything that we've done with toolkits and everything else, all the work other people have done across the country in emergency medicine, we have resources for hospitals, and now we'll be able to work with them and help them actually do this work, because it isn't an easy thing to do when you have an overcrowded emergency department and the treatment is opioids. But we can help them understand that. So this is what I think I just said. This is a slide I just edited. Yep. And that's all my references in here. And I actually want to acknowledge all of the hospitals. I didn't actually add this. I was going to write this. But I actually thank all the hospitals, the ER physicians and nurses and patients that participated in this trial and the research staff. And that's my contact information. And I think I met your 30 minutes. So I think I'll stop sharing. I'm not sure if there's comments or not. Like I said, I won't be here at 2:00.
Well, we definitely appreciate the study. This has been a issue with all of us across the country about wait times, about actual diagnoses, about following pain. And then we did break out some time at the end, like you said, for Q&A. So I did not get a high commands call. That's Dr. Raleigh in the room to see if there are live questions, because you won't be here. But I have to again get the nod from high command in the room. If there are any pressing questions that she and the group have, because you won't be here for Q&A.
I do know Dr. Farmuth will probably be able to answer all the questions that people may have about these trials. So I'm appreciative of that.
Okay, the nod has been given. Dr. Rowley, if you would field those questions there. if there are one or two questions that can be asked before she departs and then go from there. The nod has been given from high command.
High command. Wow. And I do see a lot of people in there with that view. That's really nice. Congratulations.
Hi, Annie. It's Wanda Witten-Sherney from Detroit. Thank you very much for the presentation. I just want to focus a little bit on what you said at the end, because this is life, not a fairy tale. And I do believe that the wait times for sickle cell warriors have a lot to do with institutional racism and implicit bias, but it also has to do with overcrowded emergency rooms. I have a really good hospital that has 40 beds and they have 90 patients. And how in the world are they going to get the pain medicine in that amount of time? And what kind of penalty, and even the amount of nurses that they have? You know, they're just so underserved. Is Medicaid going to do something about that, or how are you going to answer that?
So that's a great question. That's like right on the main thing. So EDs have been doing a bunch of things already in places. And so one of them is having those individualized protocols in the system. At Duke, for example, I've been there 13 years. Before I came, they were already giving opioids in the waiting room. They would look online for that patient's protocol if they had one. And then if they did, they were able to give the first dose in the waiting room. So I think we do have to kind of get creative there. As you said, institutional racism is there. So some of these motivations are going to motivate EDs to actually figure out the solution. So one solution is giving opioids in the ED. Another solution is finding other treatment spaces where you can put people where at least you can give them the first dose. And I want to say this because I say this all the time. Back in the 80s, when we started TPA for acute heart attacks, the measure came out from CMS that we had to get EKGs for people in the waiting room within 15 minutes. In an overcrowded emergency department, 15 minutes from arrival, from the time you walk in the door, that is a really high bar. That is a very difficult thing to do. Not only is it difficult to do, the number of patients to do it. Everybody comes to the emergency department with chest pain or abdominal pain. So there are probably 50 people a day that are going to walk in with chest pain. And we figured out how to do it, and we did it. And so I am convinced that EDs can do this, because first of all, it's only 2 or 3 people a day to figure this out. And you figure it out. And there are, you know, whether it's places or opioids in the waiting room or sub-Q dose in the waiting room, whatever it is. But this is also where the toolkit and consults and working with EDs, but it does start with, they have to want to do it. We do have to educate about racism, about the disease, so they understand that this is ischemia. And we don't know if you have acute chest or not. So it's a great question. It's not an easy problem, which is why we've been working with emergency providers for 20 years now and to do a lot of work. So it is possible, but we have to help. And I think the one thing individual patients can do is really try to get an individualized pain plan in your electronic health record. That will make it a lot easier to get you first.
Thank you. Just a really quick follow-up. In the waiting room, will they have their blood pressure and temperature taken?
Sure. Everybody that
Okay.
comes into the waiting room gets
In the
a
waiting,
sign.
okay, all right. Thank you.
You're welcome.
Good morning. Good morning, everyone. Thank you so much for all that vital information. I'm Norman Toomey, a longtime advocate for warriors. And I just wanted to, how do we get the toolkit? How do we get some of those materials that you have? Just starting to work with LA County General, and they're starting to do some work around there for capacity building for providers to help them better understand the population that they're working with, to see that they get the best care. So how do we get the information?
Well, that question has come up multiple times already, and we have talked about it in our group. And we were a little reluctant to help disseminate more until it actually was disseminated. So we only got it out September 3rd. We'll have another meeting in October, and we're going to have to talk about this, about how we're going to disseminate it. My thought is, you know, there are places that we can put it up online. So I think that's probably, yeah.
About how many people are in the waiting room. That doesn't matter.
You guys are level 2.
Can I let him? Okay.
I think we have time for one more question. So
Okay.
if
All right, yeah, I'm sorry. Just, oh, I'm sorry. I got to get into camera range. Is that it? Okay. I'm just not understanding the conversation about waiting times and the number of people in the room and all that. Our patients are to be triaged at a level 2, okay? If somebody comes into the waiting room with a heart attack, it's got nothing to do with how many people are in the room. You get them in the back and you get them taken care of. Now, sickle cell patients have been, ESI level 2 for a long time. Are we going to be able to get our patients triaged at the level that is appropriate for their care? And is that part of this protocol that you're talking about? Because, I don't understand the question.
Well, I can relate. So I was an ED nurse for 25 years, and I actually helped write those ESI triage guidelines for level 2. So I know what it's like to be a triage nurse. And I will tell you that just because you have chest pain doesn't mean you go back right away. It was not uncommon where I could have 15 ESI level 2 patients in the waiting room, 15, all really sick. I'm not saying that anybody is, you have to still prioritize. And you have to work really closely in the ED together because they're incredibly overcrowded. There's so many patients and there's so many sick patients. Sickle cell patients, yes. Difficulty breathing right now, yes. Heart attacks right now that have to be in the cath lab in 60 minutes to open their vessel, yes. With multiple trauma gunshot victims, yes. All of them, but you have all of them at the same time. You don't just have one, you have all of them. So Dr. Farmer can talk more about this later too, but you do have to work together as a team to put processes into place. Some of that starts with, looking at, are they actually triaging these patients as level 2? Because if they're not, forget it. You'll never get them back in 60 minutes. So that's a place to start. And then you have to start looking at your time. You have to set that bar that this is what we need to do. We need to do it, make them level 2, get them in 60 minutes. And then have a team with hematologists, with the ED docs, with looking at processes into how do we do this. Maybe we can't get you in 60 minutes, but we can get your pain medication in the waiting room. Or we're going to use this section of our ED and put you in a recliner chair or something to be able to get you pain medications in 60 minutes. And I have worked on this for 20 years. So there are ways you have to have the conversation first, be committed to doing it, and then you can have open discussions to figure out how can we actually do it. And it's only a couple of patients a day.
Please join me in thanking our presenter. Thank you for your questions. If you have a burning question, I encourage you to get that to Dr. Rowley and her team, so that she can get that to the appropriate parties and she can work out and negotiate a way in which those questions that we don't hear about today can get back to us, the questions and answers. So she's very good at doing those type of things. We thank you for your time here. We thank you for answering our questions, and we're going to move on to our next speaker. Thank you again. Our next speaker, Ms. Yvonne, you have the floor.
Can you all hear me? Yeah. Okay. So I'm Yvonne Carroll. I'm the Director of Programs at St. Jude Children's Research Hospital. I just left Paula last week, worked with her for many, many, many years. I'm an old ER nurse before I joined St. Jude in 1999. So yeah, we have a lot in common. Okay. So I'm talking about our boot camp, and it's Sickle Cell Disease Excellence in Nursing Train the Trainer boot camp. This has been a dream of mine for many, many, many years. And it's a collaboration between the University of Tennessee Health Science Center College of Nursing, St. Jude Children's Research Hospital, and the International Association of Sickle Cell Nurses and Professional Associates. So it started with actually a conversation, which is the way most things start. Like I said, it had been a dream forever because nurses are most of the healthcare workforce globally. They're over 70% of the healthcare workforce globally. And in low resource countries, they may be the only people there. And not only in low resource countries, but in rural America, they just passed a law, and I can't remember what state it was, that rural hospitals in that state had to have an ED physician on duty 24 hours. Can you imagine that? That you have a hospital that has an ED that doesn't have a doctor? I live in one of those counties where we had a hospital that the ED did not have a doctor. And not only that, in rural America, hospitals are closing. I mean, they are, so you have no health care. So nurses in many places are it. And so you may be wondering, why do I care? This is a phenomena that is happening around the world. People are leaving the nursing profession. We don't have enough nurses. When we just talked about the logistics of why can't we get everybody back? Like if you're ESI level 2, why can't you go back when you're supposed to go back? Well, let me tell you, when I worked in the ED, and this was what, 25, over 30 years ago, kind of, oh, wow. So anyway, when I worked in the ED, I worked in the only regional ED in the area, in the entire area. We had 6 nurses, we had 2 doctors, and about 4 supplemental staff. And we took care of 6,000 plus patients a month. We might have 4 traumas running at the same time. Guess who's running 2 of those traumas? Because we only have 2 doctors, nurses. Guess who else is out in the waiting room? People who weren't level 1s. So the reality of it is we would like for everybody to be back and everybody to be seen, but that's not the way the world works. So what do you want to be? You want to be one of the people who are seen. So that's why the CMS guidelines that Paula talked about are so very incredible, because hospitals pay attention to what they have to report. And just like when they talked about you had to report, you know, people who had heart attacks and were met those guidelines, that's, you want to be one of the people that they have to report, because, I mean, as unfair as it is, you know, somebody is going to not be at the top of that. And you want to be one of the ones who are at the top. So we all know that things that can be prevented, that should be prevented, that should be caught, are not always caught. And nurses are in a prime position to catch these things, to prevent further complications, morbidity, and mortality. So we know there's a huge knowledge gap. Like we all think, I don't know why people think, I talk to people and they said, my doctor said we should such and such and so and so. And I'm like, okay, but have you researched it also? Because guess what? Doctors don't know everything. Nurses don't know everything. They both get about that much training in sickle cell in school. And I kid you not, they have so much they have to cover that they don't know a lot of times why they're doing what they do when they treat you in the hospital. And they might not be like bad people or mean people or want to cause you harm. They just don't know. And so one of the things we wanted to do was address this gap. And so we knew that hospitals don't give nurses any money. And I'm telling you, as a nurse, it's a lonely path when we are fighting the same battle in different ways, but we're fighting the same battle. And so we knew that we had to get funding to have it paid for the boot camp. It is 5 days of intense training. We don't train you on how to be a nurse. If you don't know that, we can't help you. We don't train you on how to put in an IV. We can't help you with that. We train you on things that are specific to sickle cell disease and what you can do as a nurse to help prevent complications in sickle cell disease. Thank you. So we knew we had to get funding. We fund, and Ted, I cornered him a lot when he was president of GBT, and I used to say, we're getting this, and he's like, okay, and GBT had a foundation where they had grants, and they funded our first camp. Not fully funded, but it was enough to get us off the ground. And they gave us a second round. So we fully funded nurses to come for 5 days. We pay for the airfare, we pay for the hotel, we pay for the food, and we are international. We have international nurses. We've had nurses from Jamaica, from Sierra Leone, from Ghana, from Uganda, from Canada, and I think we're up to 24 states now in the United States. And we also have some incredible people. These are volunteer nurses, and I'm telling you, they are, and I'm gonna spend a second talking about them. Elizabeth Chismark, she's a curriculum developer. Brooke Clemens is our data person. Chidi Jaja is phenomenal. We'll talk about him a little more later. He's a Rhodes Scholar. Sarah Day is an assistant dean of global at UT. Our Tangela Henry was our co-PI on the first grant, and she's a nurse practitioner, takes care of adults with sickle cell disease. Stephanie Abemere doing research. She's at Duke doing research in Nigeria on sickle cell disease. Keisha Roach is one of the handful, and when I say handful, I mean handful of nurses doing basic science research. And basic science is where you get your medicines and your promises of tomorrow. Charlene Silvestri is up at Boston, and she teaches at the med school. She also runs a sickle cell clinic. Lori Vick is at University of South Carolina. She held 500 interviews of people with sickle cell disease on hydroxyurea and why they take it, why they don't take it. And by the end of, if you know her, she's just the sweetest person in the world. By the end of her interviews, more than, I think it was like, was it 70%, Pat? Like 70% of the people that she talked to who weren't taking it decided to take hydroxyurea. And she's not the type to bully, she just talks to you. I mean, she just tells you the truth and tells you to look it up and make your own decision. Salorum Ansah, she validated for our pain control. Dora Clayton Jones is in Milwaukee. She does transition. Dominique Bulgin, she is at UT Knoxville, but does work in Jamaica. Paula, you just heard Paula, and you know all the wonderful work she's doing. Kathy Burns, and let me tell you why this is important to get involved and to get hospitals involved. She was on the Joint Commissions, had a certification, and when I say had, I mean past tense, for sickle cell disease. Only one hospital in the United States got that certification, one. And Kathy was instrumental in getting that in that one hospital. And Christina Wallace is a professor and also takes care of people with sickle cell disease. And I wanted to take time to mention them and go through them because they were the impetus for this. They were the writing committee for a curriculum that we were developing, and they all volunteered their time to come. 5 days. And let me tell you, it's hard. We just had it last week. I'm telling y'all, when I say I'm exhausted, but I didn't want to not come here and talk to you all because you all are important and this is like meaningful work. So we do birth to, end of life. We teach complications that happen throughout. I'm gonna go very quickly. This is just glimpse of the agenda. We always have a patient panel, love our patients, but your doctors see you when you're sick, right? Or if you're in clinic like for that long. So they don't know you. They don't know your life. They don't know outside of clinic. They don't know what goes on. They don't know how sickle cell impacts you. They tell, they're very, very, very honest and talk about life with sickle cell disease and their journey. So I'm going to skip the low resource. We talked a little bit about that. We have a diverse student. This is the one on this one. Is Rachel. She's from Nigeria. She's doing work on newborn screening. Kolad, the one on the other end, is from Saudi Arabia. It's just an amazing, amazing space where you learn about the differences in sickle cell throughout the world. And it's amazing. We do teach people how to use incentive spirometers because a lot of the nurses teaching you don't know how to use it. And so we teach them how to use it so they can teach you how to use it correctly. We have global, we had Chidi Jaja. Chidi is amazing. He started because you have to get funded for everything. Funding for 7 clinics in Sierra Leone, 7 clinics, all run by nurses. They're going to be overseen by hematologists, but they will all be run by nurses. We talked about that. The direct impact, we did one in Brazil. And this is the Brazilian nurses. They cried at the end of the session because they said no one had ever paid attention to us. And since then, Pat went with us to Brazil. Since then, it's a train the trainer. They have trained over 100+ nurses from all over Brazil. And just incredible, incredible work and incredible. They're so smart. Nurses are undervalued and underutilized. Let me tell you, at the end of this, they had made a comic book, they made videos, they made a tool in a few hours that they had to do these things. It's amazing. The things that they are doing now, going back, is just, I can't tell you. Institutional benefits, nurses are an asset. Get them to work other than just looking at them as a line item on your budget sheet. So it's amazing the things that nurses can do. And this is it's so incredibly heartfelt, the work that we do, the networking, just the excitement that they have when they leave the boot camp. And they have so much excitement, we have to do an implementation part now to show them how to do the things that they want to do. And so I think that's it for me. I worked very hard to try to get this on time. So just these are some of the barriers. We're gonna do one. We're looking at doing one. We're working with Paula to do one for ED nurses. Thinking about working hard about doing one in Africa. I also have some people who are interested in having one in India, and some of our over enthusiastic nurses want to write a book. So, okay, I'll just skip this for now. All right, and our next boot camp is next year. It's going to be September 8th through the 12th, and our application will be open up on the ISCA NAPA website, April 11th. Thank you.
That was exciting. Let's give her a round of applause, virtually as well as in person. For those of you who've ever seen any of my presentations, you know that I honor all of our nurses. Our nurses are the ones that hold everything together. They are the glue between our consumers and the physicians and the hospital staff. So if you've seen one of my presentations, you know that our first ever executive director, she still works for me. On the 20th of this month, she turns 92 years old. She's a retired nurse who helped start the Black Nurses Association. So nurses have been our partners. We have been in lockstep with nurses. Sometimes we just go in the hospital and we ask for the nurses. We don't even talk to the physicians sometimes. I love my doctors in the room, Dr. Riley, Dr. Wanda. No, but those nurses know what's going on. And we know that we have Q&A that we will have on the end. So I would like to bring up our next speaker, our resident queen, Zamara Brandon. You're on.
Thank you so much, Annie. And I just want to say in reference to the last presentation, Yvonne, that is amazing work. I look at what you're doing as a ministry, as a calling, and something that many of us were not aware of. So thank you so much. But my name is Reverend Zamoria Brandon, actually. I'm the administrative social worker for the Philadelphia Delaware Valley chapter of SCDA. DAA. And my co-host, Michael Matthews, who's the executive director of the Children's Sickle Cell Foundation, Inc. in Pittsburgh, unfortunately is quite under the weather. And he may be on his phone listening in, I'm not sure. But anyway, he asked me to carry on for our presentation. And our presentation, as you can see, is Care for the Incarcerated with Sickle Cell Disease, a Pennsylvania Experience, Challenges, Advocacy, Support, and Resources. So this is a group, I'm very passionate about those warriors that are incarcerated that have sickle cell disease. And this probably began maybe like 20 years ago or more, where we were reaching out to try and just connect with some of our clients. And their phone would be disconnected. The hospital didn't have any information on them. But then we would go to our emergency contacts to try to reach out to them, whether it be, a mother, a sister, whoever it might be, to see if they had any information. And most times what we found out is that they were incarcerated. And so then we would have families that would call us regarding their loved one being incarcerated and the lack of treatment and care that they were experiencing. So at that time, we were working very closely with one of our medical sickle cell experts who had his own private practice. Some of you may know Dr. Roy Gay, who would be able to call and speak to the medical directors at the hospitals in reference to those that were there that were not receiving medication. They did not understand the disease and anything like that. So he worked with us for a number of years. And I just wanted to say that in Philadelphia, we've been doing this for a long time, but Michael Matthews at the Children's Sickle Cell Foundation has been doing it for quite some time as well. So we're now collaborating on the work that we're doing. And I'll be able to share some other things about that work as we move through the slide presentation. Next slide, please. So this is our objective for the presentation, to highlight the needs of sickle cell warriors in Pennsylvania who are impacted by the prison system to ensure equitable access to quality care, resources, advocacy, and support. So before we move to the next slide, I just want to say, in the state of Pennsylvania, we have 67 counties. In 25 of the counties, we have a state prison. In 10, we have a federal prison. In 5, we have federal prison camps. And in Philadelphia, we have 1 county prison, just so you know the scope of Pennsylvania in terms of where the resources are, where the facilities are. Next slide, please. So this is the overview of today's presentation. We want to cover issues, challenges, integrated solutions, CBO, hospital, and institution support, statewide efforts, advocacy, and our support resources. Next slide. So these are some of the issues that we have. I'm going to move this over a little bit. We receive reports of incarcerated persons with sickle cell not receiving care. Sometimes it's about the environment, extreme issues related to heat or cold, hydration issues, access to hematology appointments, chronic transfusion therapy, etc., pain management, inadequate pain management, and it's inaccessible to them. So they're calling their families are calling us. They're not getting their pain medication. And certainly we know that many that receive opioid medication, they're not going to administer that in the prison system. They may get a Tylenol, they may even get an aspirin, but it's because of lack of understanding. And so in this next part here, we say lack of provider knowledge about the disease. They have no understanding of the disease. They're unaware of the ASH clinical practice guidelines about sickle cell disease. They don't understand the seriousness of the disease when it comes to stroke risk, acute chest, and the potential for other life-threatening risks. Next slide, please. So these are some of the major challenges that really are the foundation of what we are hearing and understanding for those with sickle cell that are incarcerated. Number one, sickle cell disease is not listed on the chronic disease registry for the state of Pennsylvania. That is big because there are other diseases that are listed there. They know what the protocol and the treatment and care should be. With sickle cell not being on that registry, that creates a lot of problems for how someone who is incarcerated is managed, is treated, how they're cared for. And this is something that we are currently working on to change this particular challenge. Number two, education, treatment, and care of the incarcerated person living with sickle cell. As I said, it goes hand in hand. If sickle cell is not on the chronic disease registry, how would you know about being educated, the treatment and care of someone that's living with the disease? And number three, one of the challenges is, and although we've done it on some level, connecting with the Department of Corrections, with their chief medical officers, administrative leadership, and social workers and case managers, which are in the prison system. And number four is labeling the stigmatization of the incarcerated and once they're released. And what I mean by that, we all hear this terminology about, a felon, a convict, that's being used to describe people. And certainly when they're released, you have the language that's being used, ex-con, ex-offender, ex-convict. And so we're trying to change the language, just like in the sickle cell community, where you have people referring to people with sickle cell as sicklers. We are all about changing that language. So with those that are released from prison, we say that they are returning citizens. That's the language that we want to use and the language that we are using when it comes to describing people that with sickle cell that have been incarcerated, or anyone, but especially those with sickle cell disease. So those are the four challenges right now that we are working on. If you can turn to the next slide for me, please. These are some of the integrated solutions that we are incorporating. We're trying to overcome those challenges. We're consulting with the adult care team at the hospitals, social worker who works with the medical team, keeping families informed and conducting follow-up. The hematologist at the medical center works with the medical director and the prison system, providing individualized treatment plan, improving knowledge of sickle cell disease, and providing access to the ASH clinical care guidelines. That leads into the CBO being connected to the institution's medical director. We have facilitated a tour of the facility. We've shared challenges and barriers to care. We provide information and offered to connect them with the adult medical team. And then followed by, we convene a meeting with the adult care team and the CBO, working to identify areas for improvement, sharing the American Society of Hematologists clinical care guidelines, and establishing regular meetings as we can to maintain and strengthen the partnership. Next slide, please. So these are our advocacy efforts. I'm going to start with providers establish a formal education plan to educate the prison office. Then assisting with medical appointments, transportation, case management. That's something we do while working with the hospital and the prison system. Then improving communication between families and prison officials. When you have a family that calls, they are really upset. They can't connect with anybody in the prison to let them know what's going on with their loved one, that they're in pain, that they need support. And then we address issues of recidivism. You know, when someone is incarcerated, you hear about them being out for a while and then they return back to prison. We're trying to address that when it comes to having the appropriate resources in place to prevent them from having to go back. Because when you've been incarcerated, whether it's for 2 years, 10 years, 15 years, 20 years, when you come out, you don't know how to navigate in this new environment. So we are really laser focused on addressing issues of recidivism through reentry support and process of community integration. And then we in Philadelphia established a peer-to-peer mentorship. We have those that have been incarcerated that have agreed to be mentors to those that are incarcerated, but those that have been released, so that they can know that they're not alone, that they have someone that has walked the walk that they are walking, and that they can be there and they can be real with them about the necessary support and how they were able to manage and navigate and to be able to have a balanced life, balanced quality of life. And then lastly, community-based organization, assistance and support. So we are navigating between the prison system, the hospital, and the families of the person that is incarcerated, but those that come out. We want to make sure that they're able to move ahead in their life and not allow this to be a barrier or something that holds them back from being able to get employment. And we know many, especially major companies, they are employing people that have been incarcerated. So we are connecting them to those or companies or those businesses that welcome them to be able to apply, to be interviewed, and to hire them for a position within the company. Next slide, please. So upon release, we're working directly with the medical director and their team. We're ensuring that the person receives information about the CBO. We have a community health worker that establishes the care plan or continues it, providing transportation to and from doctor's appointments. Employment and educational resources are offered, and basic needs when it comes to food or housing. When they come out, where are they going to stay? I mean, some may be on parole and they have to stay in a halfway house. But if that's not the case, is there a family member where they can stay instead of having them in a shelter situation? You know, we try to provide something that's going to give them hope. You know, so if they're with a family member, even once they come out of the halfway house, it will be important for their emotional and mental well-being. Next slide, please. So these are the support and resources that we have, and I'm going to speak a little bit about each one. In Philadelphia, we have a location called the Center for Returning Citizens. And this organization was started by someone that had been a lifer. And it was a governor of Pennsylvania that commuted his sentence. And then he was able to go to school. He got a master's degree in social work, and he decided to give back by starting this center for returning citizens. So oftentimes, when we have someone that has been released, we contact this organization to be able to provide the support and resources that they need. Then, of course, we have the Children's Sickle Cell Foundation, Inc. of Pittsburgh that is engaged in this work, working with, actually, they have a partnership with the University of Pittsburgh Medical Center and Allegheny County Jail. Then we have another organization in Pittsburgh, Imagine Reentry Program, which provides support for people that are living or that are incarcerated in that particular area. We're also working very closely with the Pennsylvania Legislative Black Caucus. They are aware that sickle cell is not included on the chronic disease registry, and they're working with us to try and address that issue. And Pennsylvania Prison Society is really an advocacy organization, a nonprofit organization, and we call on them when there's someone incarcerated and the family cannot make any contact within that system. They are authorized to be able to go in to see what's going on, to meet with the person that's incarcerated, speak with the medical director and the team there. They are a very progressive organization. Then we have the Pennsylvania Reentry Coalition, which is another amazing organization that helps those that are being released from prison. Then we have the Pennsylvania Sickle Cell Providers Network, which is a coalition of community-based organizations and medical providers throughout the state. And we have made this particular issue about those with sickle cell that are incarcerated a committee that some of us are on, that we're working to resolve some of the challenges that I mentioned earlier. And then there's our organization. Then we have the South Central Sickle Cell Council in Harrisburg, Pennsylvania. And then Thomas Jefferson University Hospital, their comprehensive sickle cell program. They have been amazing. If we have someone that we know is coming out and they need a medical home, they need a hematologist or a primary care doctor, they have worked very closely with us to make sure that their program is open to providing that support that's needed. And lastly, we have the Youth Sentencing and Reentry Project. I don't know if you've heard about people that were incarcerated when they were like teenagers. And they might be in their 50s and 60s now, and they are still incarcerated. And so this particular program, Youth Sentencing and Reentry Project, we have worked closely with them when it came to 2 individuals that were incarcerated as young people. And they're also working very closely with the Innocence Project because these 2 individuals, they were incarcerated and they were wrongly accused. So we have been a partner with them working to make sure that we were able to go and testify at their hearing to be released, and then partnering them with Thomas Jefferson University Hospital to make sure that they have a medical home, they can get the support that they need. So there's a lot of resources, and we've been doing this for some time, and it was Dr. Carolyn Rowley that reached out to Michael Matthews to do a presentation about this, and I happened to be on that virtual meeting, and she was just amazed at the information that we were able to share about this work that we're doing in the state of Pennsylvania, and she wanted this to definitely be presented at this symposium that she's having. So we are honored. We're still doing this work. Our major goal is getting sickle cell to be included on the chronic disease registry for the state of Pennsylvania. It's something that we're working with right now with the Pennsylvania Legislative Black Caucus. And our final slide is a thank you. Thank you first and foremost to Dr. Carolyn Rowley for her interest in this. And I know that she wants to establish a nationwide group to address this problem. So it's something we will be talking about. But there's our contact information there. I don't know if we have an opportunity for questions or whether it will come later, but I just want to say thank you for giving us the opportunity again. I'm so sorry that my co-presenter, Michael Matthews, is not doing well today, but hopefully I carried on in a way to make him proud. Thank you.
Well, we do thank you, and you did carry on in a way that would make you proud, as you always do, as we always do as CBO leaders and partners. Just a reminder that Q&A will be at the end, and then there are breakout sessions so that you can further ask additional questions, and then you can decide which breakout session you would like to attend during those sessions. So we have our final speaker who will be coming on board. And I believe that she is live. All right. Thank you so much.
Hello, everyone. How are you? Good to be here. I know I have some slides, so they're being pulled up. Give it a second, or I can keep going. Well, just to introduce myself, my name is Ariel Crane-Buell. I'm the Community Programs Coordinator at 6Ls. Some of you may have formerly known me in operations, so I worked really closely with the sponsors, and now I've been a little bit more front-facing with all of you wonderful community members, which just means I get a chance to know everyone, and it's been just a wonderful experience for me. So my presentation is going to be on advocacy in Rare Disease Week. So a topic that many of you are probably very well versed in, but I still feel like I'm growing and I'm learning a lot. So I feel like I represent those of you who may be new to advocacy still, or maybe lack just some understanding of how to get started. But before I do that, I'm just going to share a little bit about 6Ls. So 6Ls is a national sickle cell disease advocacy nonprofit with a mission to elevate the voices of the sickle cell disease community, and with a vision to influence decision makers to propel positive change. It was founded by Ashley Valentine and her late brother, Marcus Valentine. And before I get started, oh, we want to give one moment potentially for the slides to come up. Yeah. No problem. Founded by Ashley Valentine and her late brother, Marcus Valentine. And before I get started as well, I wanted to say thank you to Kian Wellness, to Dr. Carolyn Rowley for allowing us to be here, for putting on this wonderful educational summit. And I can, again, talk a little bit about myself even before jumping into the presentation. So I first started out with 6Ls just as a volunteer. I was a young, newly graduated student. I feel like I was kind of in the pandemic era. So I was graduating and it was a dark period for many. And especially as a new graduate, looking for ways to get involved, looking for ways to volunteer. And I was no stranger to community engagement efforts. That felt something that was home to me, that I had already had experience in. Thank you. And so it was just a very easy space for me to begin to roll up my sleeves. And when I got to the blood drive, I already sort of felt at home and that I could really hope to make a positive impact. Let's see, where am I at? Oh, okay. The green button, I see it. Oh, there we go. Got it. Okay. There I am. Okay, that's what we're talking about. We talked about 6Ls. Thank you, Ashley. Okay, getting into my personal experience. So yeah, I was just talking about the blood drive. So that's the photo of me on the right. pretty new to what advocacy looked like, but that was my first exposure, was learning about the importance of blood donation, which is advocacy in and of itself. And since then, my definition and my understanding has definitely matured. And so then pictured getting the chance to be on the Hill. I'm going to talk about Rare Disease Week shortly, but those pictures are really fun to look at and bring me back to some fun and exciting memories. So advancing slides next. Okay, so advocacy. I chose this quote, if it's not in policy, it's not going to happen. Just demonstrating the importance. It was straight from the community from Velvet Brown Watts, who's a CBO leader. And then I actually have a definition as well that struck me. So advocacy, it's defined as any action that speaks in favor of, recommends, argues for a cause, supports or defends, or pleads on the behalf of others, or to put it shortly, to change what is to what should be. And then I'm going to go through a few types of advocacy throughout this presentation. So legislative, congressional advocacy, institutional advocacy, and then agency advocacy. And then I also have this lovely visual aid just to show our goals. So to raise public awareness, we do this by community engagement to hopefully change policies, and then just the broader importance of that public awareness. And also why we advocate, that's really important. It ties really well back into our mission, which is to elevate the voices of the sickle cell community. We're driven by all of our faces. That's one of our programs, to be reminded of those who have worked extremely hard to make a change in this space. And then diving into legislative advocacy. So I'm going to be talking here about Rare Disease Week and then about our Sickle Cell Disease Policy Forum, which are two events that we participate in every year. So starting with Rare Disease Week. So I wanted to first highlight some history. So this is Rare Disease Week 2018. And I'm going to make this interact. Were any of you here in 2018 or participated in Rare Disease Week at all? Okay, I see one hand. I see two hands. I see three, four. Okay, great. So the Rare Disease Week, it's hosted by the Every Life Foundation. So this is an organization that focuses on rare disease. And so of course we know that sickle cell is a rare disease. So this year was extremely important because it highlighted the engagement of the sickle cell disease community. It was the first time that Sickle Cells deployed heavy recruitment methods. In many ways, it was the first time many learned that sickle cell disease was considered a rare disease. And so in 2018, over 100 advocates applied for the travel stipend. It was the highest participation from the sickle cell disease community in the history of Rare Disease Week. And so also it had, in many ways, an effect on the Treatment Act of 2018. So moving on to now, Rare Disease Week 2024. So from our work then to now, sickle cell has a very strong presence every year for Rare Disease Week. It's an important chance for community members and advocates to be on the Hill and be in person, front-facing with legislators. And then I do have some information. So Rare Disease Week, it's again on Capitol Hill. And next year in 2025, it'll be from February 24th through February 26th. And I do have a slide just about, again, there are travel reimbursements available. So if you're interested in participating, make sure to check out their website, or I have my contact information at the end, and I'm happy to help you learn more and register if you would like. And then moving on, so the Sickle Cell Disease Policy Forum is strategically after Rare Disease Week. So this is a chance for sickle cell disease community members just to be able to speak specifically about rare disease, or sickle cell, sorry. So Rare Disease Week, rare diseases at large, and then the Sickle Cell Disease Policy Forum is again sickle cell specific. And I have a slide just detailing what it looks like. So it's a 2-day federal advocacy event. It's hosted by Sickle Cells and the Sickle Cell Community Consortium. Shout out Sharonda back there, and Dominique and the whole SC3 gang. This year it'll be again in March of 2025. And I wanted to share a little bit about our recruitment strategies. So just how we collaborate with the community and our strategic recruitment. So you'll see that we hosted 5 road shows. So with SCADI, with Dreamsicle, with Access Advocacy, and email communication, our newsletter. I also have a slide just about phone banking. And also a lot of this, a lot of the strategy behind this came from our CHIRP project, which is our community health equity research program, where we found that there was a digital divide between all ages within the sickle cell community, and that some people are more responsive on social media versus answering the phone. So this is how the strategy came about. I was able to complete close to 200 phone calls, texting, following up, emails. Some of you get my emails all the time. We just want you to make sure that you're aware if you have any questions with registering. And we found that it truly helped with our turnout. And we're excited to share that we had over 106 congressional meetings represented across 28 states. There were over 200 attendees, and 82% of the meetings were confirmed. So we're really excited about these highlights. And then also this slide just highlights an exciting fact that it was just the first time many were able to meet with their legislator. And then diving in. So next I'm going to speak to institutional and federal agency advocacy. So this is specifically going to look at ICER and our work with the FDA AdComs. So many of you know and are familiar with ICER, or the Institutes for Clinical and Economic Review, and just the importance of these reviews, as we know that a negative ICER review could potentially lead to negative effects in access and coverage. And Sickle Cells was highly engaged in both 2019 and 2020, and then in 2023 with the 2 gene therapies. And this slide shows just our engagement with ICER. So again, making sure that community awareness piece, that those of us knew that there was an ICER review happening, and then the community engagement, how to show up, how to be a part of webinar series. There was an in-person training, so through Cayenne Wellness, individual phone calls, the storytelling campaign, and then again in 2023, for the 2 gene therapies, hosting community calls, fielding sign-on letters. And this is just to show there's many ways to get involved with advocacy in written form, through meetings. And let's see, moving on to federal agency advocacy, perfect. And just again, talking about the FDA AdCom. So this is another way, another avenue to be engaged in advocacy work. So for those of you who don't know what an FDA advisory committee, this is an important way that the FDA makes their determinations on therapy approvals. So there are 3 historical FDA AdComs. So there is hydroxyurea in 1997, and then Indari, which Ashley and Marcus participated in 2017, and then Casgevy in 2023. And then just looking at how we were able to engage our community members to raise awareness about the AdComs last year. So we had a few social media posts just to educate what an FDA AdCom is, instructions, so a memo to detail how to be involved, their importance, and then we hosted Instagram Lives. Ashley and Mariah were able to share their experience, again, provide instructions on how to be involved. And we're happy to say that based on these efforts, we were able to have 31 written comments submitted. There were 13 speakers that presented. So we're really excited about the results of the FDA AdComs. Many of you were highly engaged and aware that this was happening, and were active participants. And so community engagement, that's one of our pillars of the foundation that I talked about earlier for what advocacy is. But there are several ways to get involved. You can see there's a Zoom meeting. There's Kevin Wake, who we saw yesterday. And this is just an overall summary slide of ways that we advocate, ways that you can get involved. So again, I'm the community programs coordinator and help manage our ambassador program. So we have our 2 monthly touch points. We have our T-chats, which I try and give a rundown of what's happening in the community. If you have events, my inbox is open, so you can send me your flyers so I can share them. And then our priority topic meetings. So these are educational. We bring in a speaker every month. The topics vary. We have our toolkits. We have Medicaid advocacy. So I didn't get to touch on state level advocacy in our work at the DERBs, but that's also a really important part of what we do. We have a very robust online community. So we have our social media that's very active. And then speaking opportunities. So we want to be able to connect those of you who may want to speak, who may want to present, and we try and locate those opportunities and connect you. And just another example, like our ambassadors are always in action. We have Jamila Williams. She was able to take a lot of our advocacy tools to her support group. We've had our ambassadors speak at our priority topic meetings. And then again, a screenshot of the FDA AdCom. And as I mentioned before, my inbox is open. If you have any questions about what I shared today or how to get involved in any of the opportunities that I mentioned, please reach out to me at acranebuell@6cells.org. Thank you.
Thank you so much for your presentation. We have heard 4 wonderful presentations. Are there any, we do not at this time have any live questions, just comments on how wonderful and informative the presentations have been. So Dr. Rowley and team, if there are live questions, you can now ask those from the floor. Before the question is asked, we were supposed to have someone sit in. For Paula, is that person available in the room, or will that be virtual?
Caroline Fryermuth will be virtual at 11 in the breakout room.
Okay, thank you.
Hi.
Sir, please go ahead with your question.
Okay, thank you. My name is Ken Carson. I'm a sickle cell warrior. And my question is for the young woman with the nursing education program. Yvonne, beautiful. Thank you, Yvonne. Yvonne, I want to first congratulate you on a wonderful program. Nurses are our heroes. I mean, you can't be a patient and not love nurses. But my question is this, is in your program, do you address the propagation of the sickle cell stigmas that take place amongst the medical community and how those things are propagated? Is that something that you guys address?
Yes, it is. We have several of our speakers, that's their area of research. And did I leave Coretta off of the, oh my goodness. Dr. Coretta Jenneret is, that's her area of expertise, and she published, and I'm glad you brought that up because I need to put her on the side. She'll never forget me. But yes, that's a big part of it. And we spend a lot of time talking about it. Nurses spend a lot of time sharing. What you all might not realize is sometimes nurses are clumped in the same way. Nurses who take care of people, sickle cell warriors, are clumped the same way that sickle cell warriors. People don't want to hear us. People don't want to listen to us. We're isolated in the community because normally we are such a small part of the hospital organization. So we have to fight just as hard. So yeah, we do address stigma with other healthcare providers and address how we can how they can address that on a systemic level higher in the hospital.
Thank you, Ms. Yvonne. Also, I do, before we go to the next question in the room, we have a virtual question, and then I would encourage those who are in the CVent app to put your questions in the app so they can populate here in the back end. So how does one start to get involved with Advocacy Day?
So I'm wondering if you're talking about Rare Disease Week or the policy
No, how
forum.
how does one get in, start to participate in any Advocacy Day activity?
At 6Ls. Yeah, I,
Yeah.
I would first encourage anyone who's interested in any of our advocacy efforts to join our ambassador program. So that's where we have a listserv and we keep everybody informed on what advocacy opportunities that there are, any of the ones that I mentioned. So to participate in any of our events or to join us at our monthly meetings, I would say that would be the best place to start.
Thank you.
No
You may
problem.
now take the second question from the floor.
Good morning. I'm Christopher Archie from Houston, Texas, here supporting Dorian Archie. You mentioned the nurses and practitioners are not bad people. I agree with you. But what mechanism can we put in place that they can at least listen to the patient, that they can at least listen to what they're saying as if they don't know what they need? So it's been it's not just systemic, it's been historic and it's ongoing. And so I really applaud this in this forum, but it's been an Achilles heel for me as to get, I mean, what do we need to do? Get pom-poms and wave banners and have, bands come in. But I wanted to address that with you. Thank you.
So I'll just tell you honestly, what I found the best way to do is networking, to get involved. Every hospital has advocates. They have places where people in the community can get involved in the hospital, because it's difficult if you know someone as a person and to just disregard their calls. That might not be the scientific way, but I just found networking works best. Letting people know you, getting involved inside the system, so that when they bring up sickle cell disease, they have a good thought in their mind. Yeah, that's so-and-so that we work with, it's like if someone cold calls you, you're going to ignore them. But if a friend calls you or someone calls you, then you're going to take their call and you're going to listen to them. So I've just found that that's probably the best and easiest way to get involved inside the system and on committees. Like I said, every hospital, they have IRB committees that they have to have patient advocates. They have QI committees. They have all kind of committees. And I would just inquire how you can get involved.
I think, and then also to talk with the chief operating person at your institution to give them an awareness of who you are and situations that you've encountered, because oftentimes they don't know anything about what's going on with those kind of things. And so a presence, the community has to have a bigger presence within those facilities where their individuals are serviced. And so I think just going forward, calling, making an appointment, I'd like to come in and speak with you about, about sickle cell disease and my person who comes to your hospital, to just increase awareness is really, really important.
All right, thank you. I have a virtual question, but prior to that question, I would also include in that answer to definitely seek the help of your state CBOs, your CBOs who probably have contact and can go in and assist and lobby and do some things and advocate on your behalf. So making those networks with your community-based organizations, as well as hospital committees and groups they all work in concert. The virtual question is, how can one get access to a toolkit. Now, I don't know which toolkit. Somebody talked about a toolkit. I don't know if it's an advocacy toolkit or was it the hospital protocol toolkit. So can that person be more specific? Whatever toolkits that are made available. Who has a toolkit?
Six Cells has toolkits.
Okay.
Yeah, I wasn't sure, but yes, if you're interested in any of our educational resources, I would encourage you to browse the Six Cells website. So if you go under our advocacy tools, we have a whole slew of toolkits ranging from how to advocate in the ER, to building your own personal brand, to how to advocate at the DERBs, how to share your story. So I would just really encourage you to check out the advocacy tools on the Six Cells website.
And so the other thing that Adrian just brought up is something that I've been talking about for a long time. Know who's within your institution. Those chaplains, the social workers, all of those kind of people, your voice has to be heard by them in order for them to actually support you as you converse with other people about things, And so just to get to know people within your institution and find out those champions in your institution. And for those of you who don't have champions, develop some champions within those institutions. Because that is so, so very important, that your voice can be heard more clearly and louder than you as an individual can have it heard.
Good afternoon, everyone. Thank you so much to both of you for your presentations. My name is Dorian Archie. I'm a assistant program manager for Cayenne Wellness's March on Hospital campaign. And that was my father. My question, or even more so statement, is in regards to policy advocacy. I greatly applaud the efforts that you guys are doing to look at impacting policy. I love the quote that you gave on, change doesn't occur unless it's happening at a policy level. And that's so true. Policy happens from the top down and not from the bottom up, as it should most of the time. So I wanted to, I guess, inquire whether Six Cells was doing anything to actually impact policy on the hospital level. So that's what March on Hospital is actually looking to impact. The policy in the hospitals that directly impacts what the patients are experiencing and seeing within these hospitals and ERs that they're going to seek care in, or rather oftentimes not getting the care that they should be getting in. The policy that impacts, getting money for research and going to hospitals and going to CBOs, those kinds of things are great. But I wanted to know if Sickle Cells was doing anything to actually look at policy within hospitals. And if not, I would love to partner with you guys with our March on Hospital campaign to actually look at some ways that we could actually directly bring that fight for policy change to hospitals so that patients can really start seeing a direct change in what they're experiencing and seeing in these hospitals and ERs. I know even in our last conversation with one of the nurses, she, was basically, in my opinion, undid her whole thing by saying, I can't triage, sickle cell patients over anybody else, despite, we're dying in these ERs, we're dying in these waiting rooms, being tossed out of these waiting rooms sometimes. What are some ways that patients can look at directly impacting those things in terms of advocacy and doing their own seeking policy change for themselves?
Thank you so much for your question. Perfect. I was about to say, we have a government affairs team that establishes our legislative priorities, so please.
Okay, I'm getting some into the middle, but not to steal Ariel's thunder. Thank you for your question. I'm going to come up here so you can see me. So Ariel did a fantastic job. I'm Ashley Valentine, co-founder of Six Cells. To answer, oh gosh. To answer your question, so there's multiple players, obviously, in changing policy, and sometimes what is happening at the federal level, you don't really feel it at the local level immediately. So to answer your question, yes. We are working to change policy in the way care is administered in hospitals, but we're doing it at more of a macro level. So what that looks like is you saw the presentation about CMS. So that's the Centers of Medicaid Medicare Standard. Working with CMS to share the realities of sickle cell then means that CMS can change rules and regulations when they can, so then they can start penalizing hospitals if they're not following their rules. So for example, out of the Affordable Care Act, it was meant to be a good thing, that 30-day readmission rule. And so the idea was, based on federal laws, if hospitals had patients who came back after 30 or within 30 days, before 30 days, the hospitals got penalized. That negatively impacted us because sickle cell wasn't named as one of the disease states that oftentimes got hospitalized within that 30 days. So through advocacy, sickle cell was then put on the list so that then hospitals would have to take care of their sickle cell patients and they wouldn't be penalized if their sickle cell patients were getting readmitted. I give that example because that's something that took about 6 years to even change, but that happened federally, which meant that every single hospital in the country then had to follow that if they wanted to receive federal dollars. So that's where Sickle Cell steps in, is where we are trying to impact these big systems, these big machines, because then they can create federal policy or they can issue this federal guidance that then goes to the states to make those types of changes. Another way is quality measures. So right now there's no quality measures for sickle cell disease. So because there's no quality measures, that means that every individual hospital can do what they deem as quality, and there's no way to hold them accountable. So we've been working with the American Society for Hematology. We've been working with HHS, so that's Health and Human Services. We've also been working with the Office of the Assistant Secretary, and we're doing all of that so that we can get your voices into their ears so that they can understand the realities and start to build things like quality measures so that they can say that these hospitals down here in your district, they receive federal dollars, but they're not abiding by the quality metrics that are being reported. So then they can't receive the funding. So those are the ways that we work in terms of changing what life is like in the hospital. So you might not feel that right away, but to your point, what you're saying about directly working with the hospitals, there's also space for that, and that should be happening. Just like Yvonne is working with the nurses and trying to help them understand so they can advocate at their hospital. So all of these things are important and should be working in tandem.
Thank you so much, Ashley, for that answer. And again, our breakout rooms are opening. Excuse me, our breakout rooms are opening. Thank you, Pat, for the assisted moderation. The breakout rooms are opening, giving you time to get into your sessions, giving those speakers time to get situated. Those who are also live, Dr. Raleigh.
Hi. So thank you, Annie. Great job moderating.